Yes, so I'm going to be discussing the application of a proposed HIV prevention cascade framework to try and understand how we might best monitor and improve HIV prevention programs amongst female sex workers in Zimbabwe. I don't have any conflicts of interest to declare. Female sex workers in Zimbabwe carry a heavy burden of HIV, with HIV prevalence estimated across sites as about 60%. It rises steeply with age, and together with estimates from program repeat testing, suggests very high HIV incidence of approximately 10%. This is a population that requires community-led combination HIV prevention, and since 2009, the Sisters with a Voice program has been provided sexual and reproductive health services, including HIV testing and referral, to female sex workers at 36 sites across Zimbabwe. So our objectives with this analysis was to understand whether an HIV prevention cascade framework could potentially help us to monitor HIV prevention coverage and to identify gaps in provision that would allow us to improve targeting and HIV prevention programming. HIV prevention cascades have been suggested as kind of analogous to treatment cascade tools, although there are important differences. There are a range of models that have been suggested, but I'm going to just talk briefly about the approach that we took in this analysis. So for any given prevention tool, and by prevention tool I mean a very direct mechanism of HIV prevention, so not a package or a combination of services, but PrEP or condoms, for example. For any given tool, an HIV-negative population that's at risk of HIV infection requires a series of steps to achieve coverage. And these can be summarized potentially as demand, so they need motivation, they need risk perception, a supportive normative environment to use that prevention tool. They require supply or access to that tool, and not only in terms of physical availability, but in terms of friendly services, in terms of cost, in terms of logistics. And then they may also, with the exception of voluntary medical male circumcision, require support and capabilities and empowerment to adhere to that tool over time. Once we've defined and been able to measure these steps, we can then identify where there are potentially gaps in achieving prevention coverage that might lead us to enable better identification of the kinds of interventions that might help, particularly with regards to if we are also able to look at factors associated with prevention coverage and with achieving adherence, that might help us to identify interventions that could be effective in reducing HIV incidence, be those individual level interventions, interpersonal level interventions, or structural level interventions. So to test out this framework, we used data from the Sapphire Trial, which was a trial of combination HIV prevention for female sex workers conducted between 2014 and 2016 in 14 sites across Zimbabwe. The 7 comparison sites employed the usual care Sisters program, which includes community mobilization, peer education, HIV testing and counseling, sexual and reproductive health services, and syndromic STI management. The 7 intervention sites included all of these elements, but enhanced community mobilization, and on-site ART for those testing HIV positive, and on-site PrEP for those testing HIV negative, along with adherence support. We used the N-line cross-sectional respondent-driven sampling surveys, which were designed to obtain representative estimates of the female sex worker population at each of these sites, and there were about 200 women per site. They were aged 18 or over, resident at the site for 6 months at least, and had reported exchanging sex for money in the previous 30 days. We are interested in looking both at condom use and at PrEP use together, and so we limited our analysis to the 7 intervention sites where PrEP was becoming available, because there was no other provision of PrEP in Zimbabwe to sex workers at the time. And we looked only at HIV-negative female sex workers, because this was trying to look at primary prevention rather than as HIV transmission reduction. So this left us with 611 HIV-negative women who were age 30 on average. The majority were separated, divorced, or widowed, and the majority had a relatively low client load of 1 to 5 per week or 6 to 9 clients per week. So we then chose indicators from the survey to try and describe and denote our HIV prevention cascade steps of demand, supply, and adherence. So for condoms, women who reported that they were aware that condoms could prevent HIV infection were considered to have demand for condoms. When they reported that condoms were easily available, they were considered to have supply. And they were asked a range of condom use questions, so women who reported no instance of condomless sex in the last month or at last sex with clients or with steady partners not known to be HIV negative were considered to be adherent to condoms for the purpose of this analysis. So these bars show each of these individual condom measures that we asked about, and I show you this just to show the heterogeneity of responses that you would get if you used any one of them to try and denote condom adherence. So for example, the measure second from the bottom is used a condom at last sex with a client, which is a very common monitoring indicator, and was reported by almost all sex workers. But once we asked about condom use frequency in the previous month and followed up with those who said always to just a prompt, is that really always, we got down to about 45% condom adherence. So it's really important that we choose measures very carefully when populating these HIV prevention cascades. For PrEP, women who reported that they'd heard of PrEP were considered to have demand, that they'd ever been offered PrEP to have supply, and that they were currently taking PrEP and taking PrEP every day to be adherent. We then explored a range of potential explanatory factors to see what was associated with condom adherence and PrEP adherence. These were sociodemographic and sex work characteristics, and a range of factors found in related and previous literature to be associated with condom use or with PrEP use, but PrEP was mostly with other populations at that time. We also examined the effect of being adherent to condoms on adherence to PrEP and vice versa to try and understand if individuals seem to be making trade-offs between condoms and PrEP, or if, for example, women who were unable to adhere to condoms were more likely to be adherent to PrEP. So here's a prevention cascade that we got for condoms. On the left in the red bar is demand, which is very high at 94%, as was supply of condoms, but you can see that there's a very big drop-off for adherence. For PrEP, which is a new technology being rolled out through the course of this trial, and just in those trial sites among sex workers, demand was at 60%. About half of those women who'd heard of PrEP had ever been offered PrEP, which was a measure of supply, and 16% reported being adherent to PrEP. And this left us with 55% of HIV-negative female sex workers across these 7 sites who could be considered to be covered by an HIV prevention tool at this time. And that means that almost half of the female sex workers who are HIV-negative were being left uncovered by HIV prevention. So of those 343 who were covered, the majority were covered by condom adherence only, but about 30% were covered by PrEP, a little under half of whom were also using condoms adherently to this measure. In terms of factors that were associated with condom adherence, women who were older were more likely to be adherent, as were those who reported ever receiving condoms from a peer educator, which could be considered an indicator generally of contact with the program. Those who used condoms provided by clients were less likely to report adherence, perhaps because this is a less reliable source of condoms. And those who reported a more frequent alcohol consumption compared to never were also less likely to be adherent to condoms. For PrEP, women who were a bit older were slightly more likely to be adherent to condoms, but women who were entering sex work at an older age were less likely to be adherent. But that's an adjusted odds ratio, so that kind of essentially describes duration in sex work. Again, there was some association with alcohol consumption, although less strongly than for condoms, and it seemed that women who were reporting more frequent alcohol consumption were, in some cases, but not entirely, less likely to be adherent to PrEP. When we looked at PrEP adherence and condom adherence together, we didn't find evidence that being adherent, PrEP was associated with being adherent to condoms, either when looking at an overall condom measure or when just looking at condom use with clients. We did, however, find that there were 47 women who declined to answer the frequency of condom use with a client over the last month question, and differentially, we saw that these were more likely to be women who were adherent to PrEP, which is suggestive of possible differential measurement biases that we should perhaps be keeping an eye on in future. So for sex work programming in Zimbabwe, we could conclude that there's high demand for and supply of condoms, but there are real difficulties in adherence, and this is something that's not always under an individual woman's control, because it's partly under her partner's control. In part, to resolve that problem, PrEP, which is a new technology, there's a need for demand strengthening as supply increases, and support to adhere. And we know from PrEP trials with female sex workers elsewhere in Southern Africa that adherence is a real issue. It may be that programming to assist HIV prevention in the context of alcohol consumption would be beneficial, particularly for condom use, but also for PrEP. And we may need additional support for younger sex workers and those relatively new to entering sex work. This analysis was intended to be rather exploratory to test out a proposed HIV prevention cascade framework, and as such, the measures that we've chosen are not particularly nuanced and could be much improved upon. Measures that can better get at concepts of demand and at real access and supply are needed, perhaps both for program context, but also for surveys like this. And going forward, prevention cascades, I think, really do need to reflect combination prevention and the fact that people may make different choices about which prevention tools they're going to use. So I think it's important to look at these together rather than looking at each prevention mechanism in isolation of each other. We're going to need to account for changes in time at risk, which is essentially the denominator population. This is slightly less clear than the treatment cascade, for example, which is all HIV-positive individuals, because women might, in this example, be moving in and out of sex work over time, or they might choose different prevention options in different partner circumstances. And as I said, we will need to address these measurement challenges, both in terms of describing these concepts and trying to consider how to deal with biases in self-report. So I'd like to thank very much the study participants of the Sapphire Trial who gave a lot of time to this, and also to our funders, the Bill and Melinda Gates Foundation via the MESH Consortium and the funders of the Sapphire Trial. Thank you also to members of the various working groups discussing HIV prevention cascades, amongst whom we've had a lot of useful discussions, and to the whole Sapphire study team. Thank you.
Is this working? Hello, can you hear me? If you can come up, we've got time for several questions. So if you can come up to the various numbers, we can call out your names. Any questions? Okay. Number one.
Oh, is it working? Yeah. Hi, Robin Schaefer from Imperial College London. I was just wondering, I'm sorry if I missed that, for your last analysis where you looked at factors associated with adherence to condoms and PrEP, whether your sample for that was everyone or whether it was just those who already report that they demand condoms and have access to them.
Yeah, so I chose all HIV-negative sex workers rather than taking subsets of the previous bar, for example, which you could do. So you could say, if you particularly were interested in the question further along in your analysis, or if you were running a program or something, amongst those who have a supply of PrEP, who's adherent to it, that would, that's a slightly different question to ask than collapsing all of these things and looking overall. I did that because of the relatively small number and because PrEP was relatively newly being introduced in this population. But I think going forward, then choosing which denominator you'd want to use would be something that you could consider on a case-by-case basis.
Thank you.
Any other questions? I have one question. So I think people are quite excited by the prevention cascade, but you did touch on something, which is that we're talking about structural interventions, we're talking about individual interventions, we're talking about community interventions, and physically this cascade is sort of a kind of flat thing at the best. Yep. How do you get a sort of different elements of different sides, all these things combined together?
This has been something we've been discussing a little bit in these working groups that I've mentioned, because I think a number of us first coming to this HIV prevention cascade concept were a little bit concerned that it might be interpreted to be quite an individualist, sort of behavioralist sort of model. There's actually, I don't think, any particular reason for that, but perhaps we need to think about how it's communicated from that perspective, because certainly if you were to identify, for example, a gap in supply, there's more individual level intervention, well, that's particularly perhaps structural level intervention, but structural level factors including stigma or economic resources are all things that might go into that. So it would be quite appropriate to choose a structural level intervention potentially to meet that. I think the degree to which we communicate that in the prevention cascades framework, though, perhaps, and versus having quite a simple tool versus having a more complex tool where we try and suggest these things more explicitly, perhaps it needs to go along with particular kind of guidance, or if anybody's a graphic designer and is good at thinking about this sort of thing, that would also be useful.
Thank you.
Thanks.
Any more questions? Okay, thank you very much. You brought us back to time. So I'll call the next person up, Sharon Weir, who is an assistant professor at the University of North Carolina, interested in spaces of risk and really looking at things at a much more local level. Whenever you want to start. Are you okay?
Good afternoon. I'm very glad to have this opportunity to contribute to discussion about prevention cascades. First, I want to acknowledge my co-authors and collaborators from Measure Evaluation at the University of North Carolina, and also colleagues from Uganda, Malawi, and Angola, as well as colleagues from the MESH Consortium. Funding was provided for these studies by USAID PEPFAR, the Global Fund, and the Bill and Melinda Gates Foundation. The objectives of this analysis are to apply published prevention frameworks to multiple data sets and reflect on issues revealed by the cascades. In my opinion, as with the Stroopwafel cascade shown here, the HIV prevention cascade recipe is still in the test and taste stage. The methods are the following. We applied the framework that was published in The Lancet to already collected data from place studies in Uganda, Angola, and Malawi. You heard Liz describe the cascade already, and I won't repeat the description. But in this application, our focus is on applying the cascade just to condom use. The data I will show are unweighted, although we have the weights, and could extrapolate to the country. And we applied the cascades to 4 different populations: female sex workers, men who have sex with men, transgender women, and men with 2 or more partners in the past 4 weeks. The place method was used for each of the studies. It varied a bit from study to study, so some of the measures are slightly different. And overall, I don't have time to give a full description of the place method, but it is a surveillance and program monitoring tool to identify locations to access HIV transmission networks for the purpose of program outreach. The method systematically identifies venues where people meet new sexual or needle-sharing partners. Venues can be bars, clubs, streets, parks, and even churches. These venues are visited and characterized. A representative sample of people at the venues during a busy time is interviewed and tested. Results are used to improve program coverage. The analyses I will show today are from subgroup analyses of these interviews among people who had a negative HIV test. The place method was highlighted in the UNAIDS report, Miles to Go, released at this meeting, and more information on the method is available from the Measure Evaluation website. In Uganda, sex worker status, perceived risk, condom uptake were defined as shown on this slide. Sex worker status was based, for this analysis, on answering yes to a question about receiving cash for sex in the past 12 months. Perceived risk was based on a question asking the person to rate their chances of getting HIV, and uptake of condom use on reporting ever use of condoms. The map of Uganda highlights the 30 districts where these data were collected. People were classified as adherent to condom use if they reported trying to use condoms every time they had sex, or actually using them every time, the 2 statements shown in bold. However, spoiler alert, nobody actually reported using condoms every time in this past 6 months. So our consistent use is limited to people who said they tried to use condoms every time, but sometimes they don't. Condoms were considered available if the person reported that it was either easy to get condoms or if the person was actually carrying a condom at the time of the interview. So here are the condom prevention cascades for female sex workers from these 30 districts in Uganda. These 2 cascades measure condom use, but there's a difference in the second column. The cascade on the left focuses in the second column on the perception of risk of HIV infection. So the drop off from the first column to the second column, from 1933 to 975, reflects the number of people who do not perceive themselves at risk. Of those who do perceive themselves at risk, most have used a condom, but very few report consistent use. Of these 1,933 HIV-negative female sex workers, only 124 reported consistent use. The cascade on the right is similar, but the second bar reflects those who report that condoms are available rather than those who perceive risk. Here, of the 1,933 women, 215 report consistent use. Here are the measures used in Angola. They're very similar, but because the studies varied a bit from country to country, these measures differ slightly. In Angola, uptake was measured based on whether a condom was used at last sex. Adherence was based on using a condom every time in the past 6 months. Here is the condom cascade among female sex workers in Angola. It's similar to the female sex worker cascade from Uganda. There are clear availability and consistency of use gaps. The map shows the 5 areas in Angola where the study was implemented. And this study was implemented through the Linkages Project, a USAID-funded project. Also in Angola, the PLACE study included men who have sex with men and transgender women. Here are the cascades for HIV-negative MSM in Angola and HIV-negative transgender women in Angola. You see the same availability and consistency gaps. And now from Malawi. Here's another example. This is from men who were at these social venues for the PLACE study and reported that they had 2 or more sexual partners in the past 4 weeks. Among these men, the consistency in condom use gap was greater than the availability gap. Of the 185 men who reported 2 or more sexual partners in the past 4 weeks, 27 reported consistent condom use. I have 3 brief reflections. First is about the 2 versions of the cascade that are shown up on the left. The client-centered one that looks at perceived risk versus the program-centered one that looks at availability. In our example that's shown here, the 2 cascades give the same general picture. That would not necessarily be true in other populations. Overall, the availability focus may be more readily useful to programs who could then target condom distribution based on these findings. However, one issue with availability, as the second bar in the cascade, is that it might give the impression that people who report that condoms are not available never use condoms. If you look at the graph on the right, in fact, we don't see much difference in condom use between people who reported condoms were available versus those who did not. 17% of people who said condoms were available used condoms occasionally or tried to use condoms every time, as did 17% of people who reported condoms were not available. A second reflection is about the focus on acquisition risk in these prevention cascades rather than transmission risk. Prevention cascades are currently applied to people who are not infected with HIV and do not include the impact of viral suppression on preventing HIV onward transmission. Condom cascades among persons infected with HIV, I think, would also be very informative and could be used by programs. A third thought is that, as Liz and others have mentioned, incorporating structural interventions into cascades is a challenge. One option that we presented in a UNAIDS guideline some years ago was to create a cascade showing the availability of services and structural interventions at the local level, as well as at the individual level. In this example, some components of combination prevention are available in all districts, but the full basket of services and structural interventions only available in a few. In summary, prevention cascades have great promise. The gaps in availability and consistent use of condoms present a clear call to understand these gaps and address the underlying reasons for the gaps. Other possible ways to make progress on cascades includes applying them to additional populations, improving the measures of availability, adapting them to HIV-infected persons, and integrating combination prevention and structural interventions more visibly into them. Thank you very much.
This paper is open for questions. We have time for a few. If you come to the microscope, I can call out your name. Number 1.
Hi, thank you for Robin Schaefer again, sorry. Thank you for all the illustrations of the prevention cascade concept from different countries. My question, or more is a comment, and then I would like to hear your opinion about it. My question or comment is about the risk perception part in the client-centric prevention cascade model. And you kind of already mentioned that you think that risk perception may be more suitable as an exploratory factor for consistent use. And my problem with risk perception as kind of the first step in the prevention cascade is that when you ask people, do you perceive yourself to be at risk in whatever form you phrase that question, a person may say, no, I do not perceive any risk because they already use condoms. So if you construct the cascade in this form, you may find people saying, no, I'm not at a risk, and then they form part of your gap, or your risk perception gap. But actually, they are not part of the problem. There should be in that bar later that is about the consistent use. So these people are kind of missed in the cascade, and the gaps are somewhat overestimated. So that's my comment, and I wonder what's your thought about that?
I think that's a really great point. My own feeling about the risk perception issue is that it's difficult to measure, like you're saying. It's difficult to understand what people say, how they perceived a question even. And I think it's if you construct a cascade where somebody has to perceive their risk, otherwise they get cut out of the cascade completely, then that question carries a lot of weight. It becomes a real road off the cascade. So I personally think there should be, now I hear myself so many times. Yeah. The echo is terrible.
It's echoing up here. Can you check why it's echoing?
I think it's probably too big of a challenge to try to get one question on risk perception and get it good enough so that you trust it to take people out of the cascade. So I kind of agree. I agree with your questions about it.
I have one question actually along the same sort of lines, which is, did you have any idea of what sort of the condom availability so we're talking about availability in terms of what people wanted themselves, but is there anything in terms of triangulating it with what was actually available and what was actually being used to sort of, in a way, validate what these self-perceptions of risk or need or using is in these cascades?
I didn't do that in these cascades because I was trying to follow the recipe that was in the Lancet and not stray too far off. But I think that's a really good point because people can say it's not available sort of in general when they're asked the question, but then they could have one in their pocket. They could say it's not available, but it's in the venue. So we haven't really worked through how to validate any measure of availability. At least I haven't. It could be that other people have done that. Yeah.
Any other questions from the floor? And just one thing from up here, you're all being very, very patient with the technological hiccup. I think I jinxed it when I arrived. So for our last presenter, Dr. Kimberly Greene, who is from HIV TB NCD Program Director and Chief of Party for USAID PATH Healthy Markets Project at Mekong. Please start.
Thank you. Good afternoon, and really big thank you to all of you who have hung in there with us on the second to last day of the conference, and also despite our electricity challenges. So I wanted to first note that I'm presenting on behalf of the first author, Ian Hiv, who is not able to be here. So we're really shifting focus from talking about cascades and studies to really now focusing on condom markets and how to make condom markets sustainable where you have reductions in donor funding. So I want to provide some context in Vietnam when we first started the condom market development work. So this was in early 2014, and at this time we were seeing shifts in the epidemic where there were reductions of new infections among people who inject drugs and female sex workers, but we were starting to see increases among men who have sex with men and transgender women. At this time, also, Ministry of Health had committed to the 90-90-90 goals by 2020 and to eliminate HIV by 2030. But one of the big challenges was that almost 80% of the HIV program was financed by external donors, and that with Vietnam attaining lower and middle income status, a number of donors had left or had reduced the scope and focus of their work. So then, in thinking about condoms and condom security in Vietnam, there was then some good news and some not so good news. So the good news was that with reductions in free or partially subsidized condoms, this presented an opportunity for local condom manufacturers to invest in the local market. So at this time, there were 3 condom manufacturers, and they were exporting most of their condoms because they weren't convinced there was yet a market for them. And the second is that there was increasing purchasing power and willingness to pay among key populations and the wider population. Now, the key challenges were Ministry of Health was not an active market manager at this time. They weren't so aware of what the total market approach was. And secondly, very concerning was that there were no standards in terms of condom quality that existed in Vietnam. And so the market then, as these very high quality, free or low cost condoms were declining, the market started to flood with very poor quality condoms and fake products. And we also observed, as we looked at the proportion of the market between free, socially marketed, and commercial, it was variable, but where free and partially subsidized represented between 32 and 50% of the market. So the question was on how to address market gaps for condoms and sustain key population access to quality and affordable condoms. Well, I'm glad you asked. So the USAID Path Healthy Markets project, which started in 2014, was really designed to complement efforts in country around generating domestic financing for HIV and really working with private sector, community-based organizations, and social enterprises. There were 3 key objectives. Number 1, to increase local and private sector investment, and also to boost the supply and demand for private sector HIV commodities and services. And so these cover a range of commodities, including, of course, condoms, lubricant, needles and syringes, and HIV test kits. And then also with services, HIV testing services, PrEP, NPEP, and ART. And so while I'm focusing on condoms, condoms fit within the larger domain in Vietnam of combination prevention. So we applied 6 steps towards market development. And the first, which started in 2014, was really about generating data and insights regarding the current policies, the current condom market in terms of volume and dominant brands, and then also understanding key population preferences, willingness to pay, and utilization. The second step then had to do really with us working together with key population organizations and others to start to segment preferences around condoms and also willingness to pay, and also looking at price sensitivity. And then a key step was really taking that data and talking to the condom manufacturers in country and really pitching their investment in the local market. This also included identifying distributors and retailers, including key population CBOs. And then we worked towards boosting demand for condoms, again, within the context of combination prevention. And so this involved a number of partners and online reach, as well as more traditional outreach efforts. And so then at the policy and systems level, we advocated for a minimum set of standards for condom quality based on WHO pre-qualification. and then worked with Ministry of Health to build out their understanding of the total market approach and how they can apply that for planning and budgeting. And so in Vietnam, there's really been this progression from free condom distribution, then to a big push around social marketing, and from 2014, commercialization. And these condoms that are represented up here are some of the commercial brands that have been developed that are more focused towards the key population market. So in understanding the commercial market with key populations, it was really important to assess willingness to pay. So from the data we generated, the majority of key populations were willing to pay for condoms, either at the lower price or the median price for a commercial condom. And so then we established a supply chain. So one condom called Gallant, this condom is manufactured by Medivice 3S. And in order to ensure availability of the condom for key populations, this involved really developing a new supply chain, partnering together with key population CBOs and social enterprises who then sold condoms at commercial prices to peers through hotspots and pharmacies and hotspots, and also through online marketplaces. And then in addition, we also worked with the manufacturer to make their condoms available through the wider market. And this is a quote from one of the social enterprises, one of the directors. He says, "Our clients like our products and they're willing to pay. We're now profitable and we can sustain and grow our work." So yes, I mentioned condom promotion. These are some of the images with promoting condoms and lube. We also did a lot of promotion of condoms and with PrEP and U equals U. Some of the promotion was brand agnostic, and some of it was really focused on supporting some of these manufacturers. So now I'll turn to some of the key results. So we saw a growth in condom sales in the key population-focused markets, and the impressions of some of the brands. There's a quote around Gallant, essentially saying that it was a condom brand that was appreciated in the MSM community. It was seen as being really modern, and the super thin version in particular was appreciated. We also looked at shifts in the non-traditional outlets. So these are the brothels, bars, hotels. And so here then saw a significant decline in socially marketed product available and a steep increase in commercial product. And then working with the different private sector entities across the supply chain, we ask them every year about their investment in the condom market and their forecasted investment. And so this indicates a relatively healthy growth of investment. And then in observing now the overall market up until 2017, we see stabilization. So importantly, working at the national level with Ministry of Health, the Ministry of Health has adopted a total market approach commodity calculator, and this has been embedded in the annual planning that's done by provinces, where they need to forecast what they need in terms of commodities. And this has really helped to tease out what proportion of each key population would need the government to buy condoms that would need to be distributed for free versus populations that are willing and able to pay. And then really importantly, Ministry of Health also approved condom quality standards in April 2017 and are starting to enforce those. So what are the key takeaways? Number one, for us, really generating market and consumer insights and also brokering and facilitating identifying distributors and retailers. That was really invaluable for securing local condom manufacturer commitment to investing in Vietnam. Secondly, increasing the capabilities of key population CBOs and social enterprises was really essential for developing this more key population-focused market. And that partnering closely with Ministry of Health from the start increased their ownership and stewardship over more nuanced condom and other HIV commodity planning. This is a quote from a leader within Ministry of Health, and he basically says that TMA is helping them to better target their finite resources. So in conclusion, TMA has been very beneficial in Vietnam in developing a more secure condom market. The learnings are really helping us in looking at market development around HIV self-test kits and other commodities. But last key takeaway messages is that Ministry of Health will need to continue to grow and develop as a market manager. So I'd like to acknowledge the CBOs and social enterprises that we work with, Ministry of Health for their leadership in this area, USAID for their support, our private sector partners, and my PATH colleagues. Thank you.
So again, this paper's open for questions. If you come to a microphone, I can call you. Now it's all working. While we wait for people to think about questions, I just wonder, so we've had social marketing in the past. I remember in the 90s with PSI and then sort of trying to boost demand. And do you have any concerns around whether this will drive a kind of more inequitable market as it goes forward with different quality of condoms in the kind of free sector versus the willing to pay sector?
Yeah, so I mean, I think fundamentally the Ministry of Health being a steward of access and really helping to manage the market, our role is to help them to make sure that those that are not able to pay have access to free condoms. But that at the same time that there is a robust market. Because what happened in the past in Vietnam is there was no market because condoms were free and they were very high quality or they were very low priced. And so we've then gone through this learning about how to transition to a true commercial market. And so there is a vibrant market now in Vietnam and there is high willingness to pay among the majority of key populations. So that really sets up Vietnam for a more sustainable future for condoms at least. We have a question in number 2, and then number 1. Oh, number 5. 2. Go ahead.
That was great, thank you. I'm just interested, how do you reach those small percentage of people, perhaps with lower socioeconomic status, who can't afford to pay without eating into the commercial market and the stability of the market you've created?
So I think because of Vietnam's economy, you saw the proportion of of free condoms basically, and those free condoms are available through the government budget and also through Global Fund, and it's relatively small. The commercial market is now dominating. It's now at around 84%. So the relative proportion, the overall condom market is much larger than the key population market. And so this lower level of free condoms now that are available does not seem to have an impact. But if there were a donor that came in and flooded the market with several hundred or 10 to 20, 30 or more million of condoms, that would have a significant impact, I think, on the commercial market. And that's where it's really important for governments to coordinate across different donors.
Number 1.
Hi, thank you for presenting these results for this country in particular. I was wondering whether you can comment on the possible generalizability of your results to other countries, either in the region or elsewhere, and whether you see other countries potentially also transitioning from this free condom distribution system to more market-based approaches.
Yeah, I mean that's a great question, and I think there are a number of governments and other partners that are looking at that in other lower and middle income countries. I think there are many principles that are applicable. One variable, though, that is different in some Asian countries where you do have condom manufacturers in place is that you have that ready local market to nurture. There are other countries that may not have condom manufacturers in situ. And so that could present challenges, but I'm sure there are other ways to address that.
Number 6.
Yes, good afternoon, I'm Dina. I'm talking on behalf of I-Series E and TGU. I'm very interested in how you work together in your research with the peer groups. How did you found these groups in Vietnam, and how was the approach in working conjointly?
Yeah, so we put in place a number of different sort of mentoring, learning, and also financing at the start with CBOs. So number 1, we worked together with a social enterprise capacity building organization in Vietnam called CSIP, and they were paired together with CBOs to help them in business planning. And then in key metrics that they would put in place. We also did training and marketing skills. And one of my colleagues, Tom, who's in the audience, she's really spearheaded that. And that now includes online modules in how to develop a small business as a community-based organization. We also offered small grants in the beginning, so there was less risk to the CBOs so that they could apply their business plan, see how it went, titrate, adapt it. And so in that way, we provided a cushion or a buffer so there was more time for learning. And the CBOs that we work with thus far have been, for the most part, very successful in their business approaches. And if you're interested in learning more, Tam and others can share some of the tools and also some of the lessons that we have from Vietnam.
So number 5, and this will be the last question.
Hi, thank you for your presentation. My question could be a little naive, but I was wondering, can the total market approach be applied to services rather than a commodity like condoms? For example, can we use it to increase demand of testing services?
I think she's asking about services. Can it be applied to services as a model?
Yes, yeah, that's also a really good question. Yes, it can, and I think we've definitely moved from looking at total market approach for commodities now to services. And again, using the same principles, really understanding preferences, willingness to pay, and then looking within the market to see what's available. So in Vietnam, there was a strong demand for services that were outside of the public sector. And there are 3 private clinics that were set up by different key population groups. And these are pure private sector clinics, but they offer relative low prices compared to some of the other private services that are available in Vietnam, and have quite high acceptability, a lot of usership for PrEP, for ART, STI services, testing, and more than that.
Any more questions? Thank you very much.
Thanks.
So if you could all just give a big applause to everyone for giving us a very nice range from the paying people not to have sex or paying people not to get STIs all the way down to encouraging people to sell condoms, and we will close this session.